to introduce the cervical deformity section now. And we're going to begin with a great talk by Adam Schimmer on so many numbers. Which are the most important ones? All right, next we're going to have a talk by Hanjo Kim, who's going to help us understand where the best place to start and stop our fusions are.
Thanks for the opportunity here, especially Themi and Jason for having me a part of this. So I'm going to talk about some factors that we use when we're trying to decide on some of the levels for these types of operations that Dr. Shaffrey just demonstrated. Here are my disclosures. So here's a list of things that I consider. One is the type of deformity. So you could use the Ames classification, the Heikel-Kohler European CSRS classification, and some other ones that we'll talk about as well. But I think type of deformity is important to think about as you think about the algorithm and level selection. Next is your anatomy. Obviously, if you have an area where you want to do an osteotomy and you have a vertebral artery that's very close to that area of the osteotomy, such as a C7 PSO where you have a low entry vertebral artery, that might not allow you to do that, and something that's going to determine your level selection. Anchor integrity, I think, is really important. And usually I would prefer a large, robust size C2 screw over a lateral mass screw, which I think the bone quality is much more superior. You could get 4.0, 4.5, 5.0 screws into C2, whether it be pars or pedicle screws, provides a stronger anchor than lateral mass screws, which are much shorter and thinner. And then osteotomy selection and location. So we've learned through some of the work from UCSF that if you do a 3-column osteotomy, for example, at C7 or T1, you might be at high risk for C8 nerve root issues. So the tendency to move your osteotomy, 3-column osteotomy lower, is obviously going to affect your level selection for surgery to gain stability and to make sure you have enough fixation points distal to that osteotomy site as well as proximal. And then, of course, pre-existing stenosis and spondylosis, and especially in cases of basilar invagination and myelopathy that are going to affect your level selection. So here are some of the classification systems that I was talking about. The top two are ones that we're familiar with. The lower one is a newer one, came out by the cervical section of the ISSG, but the difference here is that the top two are descriptive deformity classification systems. The lower one utilizes dynamic radiographs in addition to the static radiographs. And I'm going to go into some of the details of that. So the Ames classification is extremely comprehensive, but it's based on static radiographs with 5 modifiers. So you could imagine if you're describing a deformity to a colleague, it may become pretty difficult. For example, you may say, oh, well, this patient has a CT 0, +1, +1, +1, and 0 type of deformity. It's probably hard to kind of communicate with that sort of method. This is the Heikel-Kohler classification through the European CSRS, and also incorporates some cervical alignment parameters in addition to the global alignment. So cases, for example, that Dr. Shaffrey just demonstrated where the cervical spine looked like there was a deformity and may, on some deformity parameters that were described by Adam, could meet criteria for cervical deformity. But if the driver for that deformity is lower down because of global balance issues, obviously the cervical spine does not need to be addressed. So the reason why dynamic radiographs has received some attention is because if we looked at some of the earlier works through the cervical section of the ISSG, what we've seen is that the alignment and extension for these patients, whether they be supine or extension radiographs that we could obtain, they're going to change the type of operation that you do for these patients. And if you obtain these radiographs regularly, it'll sometimes make you say, well, I need a 3-column osteotomy, and then your mind will change after obtaining these additional imaging that's necessary. And if we look at classification systems out there that try to talk about level selection, they always incorporate dynamic radiographs. So this is a very successful demonstration of a classification system that we may all be familiar with, which is the Lenke classification system for AIS. You cannot necessarily classify a Lenke curve without having left and right bending films. And the purpose of this classification system is to designate fusion level selection for these types of deformities. So this was put out by the cervical section of the ISSG into 3 main types of deformities to try to keep it simple. Group 1 were patients characterized as having flat neck deformity. So based on their extension radiographs as well as their standing radiographs, what we found is that their cervical lordosis is not enough to compensate for a given T1 slope, so they have a persistently elevated C27 SVA. These patients, it was proposed, usually could have a fusion that extends through the cervical spine for their cervical deformity and anchor points that extend through the cervical thoracic junction and no further down. Group 2 patients who have focal deformities within the cervical spine, they have normalized C27 SVAs, and these operations could usually stay within the cervical spine. Group 3 patients are patients that were shown just before by Dr. Schafferly with cervical thoracic drivers for deformity with high T1 slopes with an elevated cervical lordosis in an attempt to compensate for that elevated T1 slope. But because the T1 slope is so high, their C27 SVA is still elevated because it can never get to that point to fully compensate. Those patients need 3-column osteotomies to normalize their T1 slope and to allow them to have a more normal posture. We've done subsequent studies on this classification system demonstrating that the surgical strategy is different for each type, and pretty good reliability, anywhere from 82 to 90% inter and intra-observer reliability through all training classes, residents, fellows, as well as attending surgeons. So here's a case example of a type 1 73-year-old with rheumatoid, difficulty with some horizontal gaze and myelopathy. He presented with this sort of deformity. Here, if we apply the classification, T1 slopes 30, cervical lordosis is actually kyphotic at 25, and only goes down to about 15 degrees of kyphosis in extension. His C27 is elevated, so we would say that in this particular patient, where the T1 slope is relatively normal, this would be a group 1 patient characterized as a flat neck. So because of that, the level selection for this patient is an operation that extends from C2 down to LIV that extends into the cervical thoracic junction. So that's exactly what we did for this patient. This is a CT scan demonstrating the areas of autofusion for this patient, not only anteriorly, but also within the posterior facets. So because this was a group 1 flat neck, we proceeded with this sort of operation, which was an anterior osteotomy through the 5-6 segment, buttress plate, followed by a single posterior column osteotomy to normalize the patient's alignment and to achieve this sort of result at the post-op time point. Here's another case of a 67-year-old with myeloradiculopathy. So this is where myelopathy is obviously going to affect your level selection. If you had to address the cervical deformity alone for this patient, and if they had disability that met criteria for surgery, you may say, well, just looking at the radiographs, you could tackle this with a single level ACDF at 3/4 through the apical kyphotic segment. But we could see here on the flexion extension images, the C27 SVA is still relatively maintained. The T1 slope is normal. But on the MRI, there's multi-level stenosis, multi-level not only central stenosis, but foraminal stenosis, suggesting that just an isolated apical ACDF is probably not going to be sufficient in the treatment for this patient. So this is a case where it's a group 2 focal deformity patient within the cervical spine, utilizing stenosis as your deciding factor for level selection. We decided to do a 4-level ACDF with restoration of cervical lordosis and good alignment. Now, this is a type 3 deformity, a 63-year-old patient who had multiple prior operations, including a history of infection, DJK, PJK, you name it. By the time I saw them, she presented with this sort of deformity. She had prior CDI instrumentation distally that was taken out for scoliosis surgery. So she had a fusion that effectively went down to around L2 or L3. You can see here on the supine images or surrogate extension x-rays, T1 slope is severely elevated, even in the supine images, maintained at 90, which is not physiologic. CT scan demonstrating an area where she had her prior PJK that was fused, and then a traumatic fall with DJK where she had her revision operation. So somewhat of a complex situation. You can see here the cervical lordosis attempts to compensate for the elevated T1 slope of 92. So this is a type 3 patient. Luckily, the spinal cord is not very compressed, but because of the type of deformity being a type 3, we basically decided to do an operation that was centered around the T3 level with a PSO through the segment and a restoration of cervical thoracic alignment and overall restoration of global balance in the coronal and sagittal planes here with this selection. Here's another case where vertebral artery anatomy is going to change or confirm your surgical plan. Here's a 12-year-old girl with severe congenital anomalies within the cervical spine as well as in the upper thoracic spine. Here you can see just on the imaging studies that there's what I would call a cobblestone spine. You could try to classify this based on the congenital scoliosis classification, but it becomes really hard to classify because of the multiple permutations with which these patients can present. But left and right bending images, dynamic images, and a CT scan demonstrating solid fusion, congenital fusions throughout multiple segments within the cervical spine, C3 through C6. And then you can see here the C7 hemivertebra, and CT scan demonstrating the solid fusion through the congenital segments. But the vertebral artery assessment demonstrated that actually on the side of the hemivertebra at C7, the vert actually entered at C6, confirming that if you do a hemivertebrectomy for this patient, you can do it safely without being too concerned, as long as you don't go out too lateral on your dissection. So this patient underwent double PSO within the apical portion of the hemivertebral resection of C7, in addition to the apex and the thoracic spine, based on the coronal deformity with this result. So some people may ask, well, you go to C2 all the time. When do you ever go to C1, or when do you go to the occiput? And I'm going to show a case here where the occiput, I think, is justified to utilize as a UIV. Otherwise, I would either try to stop at C1 or C2, because I believe that fusion to the occiput is incredibly disabling, and it's also really difficult to really put the patients in the correct position. This was a patient that has severe rheumatoid arthritis that has failed treatment with biologics. 49-year-old, presented with progressive quadriplegia for the last 3 weeks. On presentation, she had 0 out of 5 on all motor groups, although she did have sensation distally. She was wheelchair bound. This is her cervical spine demonstrating severe deformity. And to demonstrate the extent of her rheumatoid arthritis, you could see complete aberration of multiple joints, dislocations of the distal radius in the wrist, as well as glenohumeral arthritis. Here's an image demonstrating the basilar invagination on the MRI and cervical stenosis that she has in the subaxial levels. And you can see here there's a significant impression of the odontoid within the brainstem, and I think that portion is the medulla. The neurosurgeons here could tell us. Here's some axial cuts throughout the cervical spine demonstrating central canal stenosis as well. And CT scan demonstrating really that the articulation on the occiput is actually on the C2 articular surface because of the erosion of C1 that has developed because of her underlying disease. So this is a patient that I would choose to go to the occiput because it helps you reduce the basilar invagination. I actually did a distraction process with a laminar spreader initially intraoperatively, utilized fluoro to release the articulation on C1-2 anteriorly with the freer to allow us to achieve the reduction that we needed. And this is our post-op image and our immediate post-op image there. You can see our post-op MRI just out of curiosity to see how much of a decompression we were able to achieve. We were able to bring the odontoid down about 1.5 centimeters. And you can see here on the axial images, the prior area where there was an imprint on the medulla was now free and clear, and the patient had improved significantly neurologically. Subaxial decompression actually that was also performed with a good decompression for the subaxial central spinal cord compression. And this is the patient at 6 months walking with a rolling walker and regaining her neurologic function. Thank you very much.
I have one for Hanjo. So I enjoyed your talk and the selection of UIV, LIV, and the classification system. One of the deformity types that doesn't fit so nicely into that classification is a dropped head, because it can look rigid in a flex-X unless you put the patient supine. So technically it's like a cervical thoracic junctional deformity, but if it's truly supple and flexible, do you have to go pretty low in that case, or can you stop up at like T2 or something like that?
I mean, I think if you have somebody with a dropped head, I'm guessing like the T1 slope's pretty high, their C27's really elevated, and their cervical lordosis is probably like half of their T1 slope. Is that the patient?
Well, it would be someone who's sagittal backward in their thoracolumbar spine with a low T1 slope, and then the dropped head,
very high pelvic tilt.
Dive. So C2 is really high, like those examples that Chris was showing with high C2 slope, low T1 slope.
Yeah, I mean, I think you know, if, in that case, I would probably call it a type 3, and I would go long, you know, like C2 to like past the cervical thoracic apex, and past the thoracic apex down to like T10 or T9, depending on what the radiographs look like.
Yeah.
Yeah,
It's
I'll
always
just
tough to-
add, you know, wherever you go, wherever you pick is going to be wrong. So what's happening is I usually go down to T4 because that's the origin of the semispinalis cervicus, which has most of the cervical extension moment. So I go across that entire area. But what's going to happen is that, you know, those patients, I warn them, there's probably a 50% risk over time that they're going to develop DJK because they've got a underlying muscular problem. And I've sent off muscle biopsies and everything else, and sometimes stuff comes back and sometimes it doesn't. But then you go down, you know, to me, then I go down, the next stop is usually either, you know, the thoracolumbar junction. You know, some people say you take it to the first couple lordotic segments, and then they seem to pitch forward. So I tell a lot of people that I'm doing a drop head case on, this may be one of 3 or 4 or 5 operations that eventually results in you being fused to the pelvis. So, I mean, I have 2 or 3 or 4 of those patients that are fused from C2 to the pelvis because I've slowly marched them down the spine. So I don't have, we've tried rehab, we've tried, you know, all sorts of different things to do it, but I think it's a fundamental neuromuscular problem, and I think that unfortunately you're at risk of end up doing very, very large cases.
I mean, I think the answer was contained a bit in your question for me, is that they had the ability to retrovert, so their lower compensation was actually intact. And one of the things I think we're guilty of, just like we were in Parkinson's disease, is we lump all neuromuscular dysfunction together. And really, my belief is we have to do a much more specific, patient-specific assessment of the exact nature of their extensor muscle dysfunction or their neuromuscular control to try to figure out our termination level. In a sarcopenic patient, age through senescence leads to sarcopenia. I agree with Chris. We've actually been taking those patients down to the pelvis at the index operation when they have a cervical thoracic deformity and they're sarcopenic. But I think it's more complex than just saying, oh, they have a dropped head from a neuromuscular deformity, they need to have this LIV.